I'm going to talk about two topics. One of them is of definitely general surgical interest, which is gynecomastia. The other one is more cosmetic, which is hair transplant. And we are all aware of the condition because it's very common and it's being handled by different specialities. And as far as the etiology goes, you'll find that mostly it's idiopathic. Other than that, you'll have a lot of patients with some hormonal imbalance, hypogonadism, hypothyroidism. So it's very essential to investigate to make sure what the reason for the problem is. It could even be drug-induced. But as far as the treatment goes, the important thing that we need to emphasize is it's not a medical condition, but it's more of a self-image. Most of the patients who are coming for correction of gynecomastia are doing it to improve the self-image because it's a major cause of embarrassment and also it's psychologically disturbing to the individual. With regard to the awareness, you'll be very surprised that the patients are extremely knowledgeable. A lot of information is available in the net. There are discussion boards which actually talk about the different problems, and it also tells you who are the doctors who are doing the surgery, what type of surgery would be done, and there are even pictures of before and after surgery patients, and also in terms of results, the other patients are actually evaluating the quality of results. It is to this extent that the cosmetic surgery has gone in terms of net evaluation. I'm just showing this. This is something which has appeared in one of the blog sites which expresses the emotional content of the individual who has actually gone for this surgery. He has been abused in college, in hostel in terms of ragging and lots of emotional trauma. And the same patient has been advised where to seek surgery, what type of procedure will be done, and what exactly would be the recovery and what will be the cost. This is the amount of information that is actually available. This is one of my own patients who had actually put these pictures on the blog, and other patients were there to, the prospective patients are evaluating because you can see the amount of information that is there from before surgery to about 5 months after surgery. The pictures have all been put there. And there is another patient who has had a procedure done, and you can see the last line here. He says, if you tell who the person has operated, it will help us to avoid that surgeon because the quality of result is poor. So when we talk about results and we talk about marketing, this is a two-way weapon. If a good surgery, good result, it produces more patients. A poor surgery, the same amount of people are actually exposed to the results which you are generating. So to achieve a good result, we need to evaluate the patient very critically. This is the grading which we follow, 1, 2, and 3. As you can see over here, you see the different sizes of gynecomastia from grade 1 to grade 3. We need to evaluate and see whether it's only obesity or presence of gland or whether there is ptosis, or there is also a condition called puffy nipples, which I'll show you. This is pure obesity. This is only gland. You can see this is a gland with some amount of ptosis. This is actually a gross ptosis, almost akin to a female breast with ptosis. This is the last condition which we talk about, which is puffy nipple. It's a very specific condition where it's akin to something like a tuberous breast, but in a male. So what we do is routine investigations, including hormone profile, and then we actually try to see what would be essential, whether it's going to be a liposuction or it's going to be excision of gland. It's a combination of both. And sometimes we might do a procedure which involves skin tightening also. We could do this totally under local, or it could be combined with sedation or general anesthesia, depending on the comfort of the patient and the surgeon. But whatever be it, the crux of it is going to be tumescent technique, as my senior colleague, Dr. Murugesan, had explained. We inject that area to make it nice and tight, which fluid, and also it has adrenaline and some xylocaine. And then we preliminarily do the lipo to suck out the peripheral fat, and then the gland excision is done as a conventional Webster's procedure. This is a power assist where the cannula is actually vibrating, which results in the fat getting dislocated and then it's sucked out. I'll show you some examples. Gland, then the excision is the procedure which all of us are familiar with. The incision is made in the lower half of the areola and the underlying gland is removed. Now, you may ask what exactly is the reason why so much is being talked about for a simple condition like gynecomastia. The gynecomastia is being handled by general surgeons, by pediatric surgeons, by plastic surgeons, by cosmetic surgeons. So then why this difference? The difference is it's no longer showing what has been removed as a gland and saying that, you have been cured. There's no need for that person to actually go through the surgery. It is not, if he's worried about what the problem is, we can safely assure him that everything is normal and there is no need to go for the surgery. But if he is ashamed about it, then we need to do surgery. And we need to do such surgical procedures, produce such results that he is able to expose his chest when he goes out. It's not something that he's worried with his shirt on. He needs to go to the beach. Then we need to do some surgery where the scars are the least and the results are gratifying. You can see these are the before and after pictures of patients who have gone for liposuction. You can see the improvement. If the gland is not there, then lipo itself can produce the result. When the underlying gland is there, then we need to do excision of the gland. The lipo is done from the periphery, and the underlying gland is removed through the areola. You can see the before and after pictures of this. All these patients with different types and sizes of gynecomastia. You can see even in such a large gynecomastia, this is hardly about 10 days after surgery. You can still see the plaster marks. You can see the amount of improvement that has been achieved. This boy was hardly 12 years old, not an age to operate upon. The reason we operated was this child refused to go to school. So if we tell them that you need to wait till you're 16 or 17, we are going to basically spoil his education for at least 4 years. He's not going to go to school. I got the child to be evaluated by a psychiatrist, and then we decided that he needs to have this procedure. The amount of improvement was so significant, the boy was ready to go to school immediately after surgery. So it illustrates to what extent the boy can be, disturbed psychologically. These are all different patients who have had all these procedures. Now I'm going to show you a little different procedure, which is, this is actually a Klinefelter's, which also comes quite frequently. You can see the amount of improvement. They are almost breast-like as compared to a real gynecomastia. A Klinefelter's presentation is almost breast-like. Now, you're going to talk about something which is a little different. This is not just gynecomastia. This is about liposculpturing. And what we're talking about is trying to see whether we can generate the type of cuts that we're able to get in a person who's having gynecomastia but wants to look a little different in terms of pectoral etching. You can see the before and after pictures. This patient presented with gynecomastia, but you can see the result that we have produced. We actually done the dermal etching along the free border of the pectoralis major. What you see on the side, that is it's actually not the free border. It's actually under the dermis. We have removed more fat to give an impression that it's actually the pectoralis. And again, you'll find that in these patients who have well-developed pectorals or who are looking for a correction of gynecomastia, the nipple and areola will actually be pointing down. Unlike the regular gynecomastias where the classic picture will be the nipple will be facing directly forward, here in all these patients you'll find that they're actually pointing down. This is what you will get in a patient who is looking for sculpturing or he has got good pectoralis. Now you can see all these patients where the difference, it's not just gynecomastia, but it is more of pectoral etching and also shaping the chest. Again, you can see the difference between the before and after pictures where the nipple is actually pointing down. It looks as if the chest is full, and also you're converted a gynecomastia type of chest to a person who is looking more sculpted. Sometimes we need to fill fat. If there is actually a bony deformity, we sometimes fill fat in front of the chest. If it's an excavatum type where the gynecomastia appears to be more pronounced, then we need to do fat filling. When you have very large gynecomastias, previously we used to do skin tightening procedures, but we are able to reduce that purely by suctioning, where we do multi-layered suction right from the depth to the middle layer up to the dermis. And this allows the skin to retract significantly, thereby avoiding scars. You can see the before and after picture of a patient. There's a lot of bruising because of extensive lipo. But you can see the difference in the chest wall and the size of the chest after the surgery. Sometimes you can have unsatisfactory results in terms of contour, where there's a depression, or sometimes excess skin has been removed, or sometimes there is scar hypertrophy. Gynecomastia is actually a trivial condition as most of us used to think, but it has reached enormous proportions where it forms a bulk of a plastic surgeon's practice because a lot is expected from the patient in terms of producing the result. A good result changes not only the lifestyle and also the body image of the sufferer, but as I mentioned to you, it could be a source for referrals for more and more patients to have the surgery. Maybe people are aware, or I'll just try to see how best I can explain this procedure. Hair transplant is almost about 55 years since it began, and probably even earlier bits and pieces were being done. I'm just going to show you some pictures of my own patients and how things have changed from what started off about 25 years back. The hair was growing, but it looked very doll-like, to the bottommost picture where you can see that the hair is looking much more natural than what it used to be earlier on. And again, you can see the top left-hand corner, this picture shows, which is about 25 years back, this was the era of punch grafting, where holes were about 4 millimeters in size, and it used to produce that type of doll's head type of growth. And now the holes are almost made with a 21 and a 23 gauge hypodermic needle, and hairs which have been dissected that level, each hair is just bare hair is inserted into those holes. So we need to look at patient selection, where the patient is mature enough to understand that he can improve the situation, but it's not possible to get the entire head covered by hair. And also we need to look at how good the quality of the hair is at the donor site, which is typically the back of the head, which is called the permanent hair or the safe area. You'll find that most people, when they bald, they still retain hair in the occiput and the parietal, and that is the hair which is used for this type of surgery. So we have to be very careful when we choose very young patients, because they are doing it under peer pressure, and we should tell them that it's not possible to get the entire original look back, but certainly we can improve depending upon the quality of the donor site. We are basically doing what is called follicular unit transplant, which is the base unit which contains the pilosebaceous apparatus as well as the hair. A typical unit has 1 to 3 hairs along with the... now, you can actually see in this picture, this has 1 hair, and then you have a 2-haired unit, and then you have a 3-haired unit. And these are how it is in nature. We actually take a strip and then start dissecting it under microscope and separate each hair as a unit. If they have 1 hair, it's a 1-haired unit. If it's 2, it's 2-haired. If it's 3, it's 3-haired. And you can actually see the picture on the right side illustrates to what extent the hair is actually skeletonized, so that it can be introduced into one of the finest holes that we can make with a hypodermic needle. This is the donor side that we talked about. And then when we talk about dense packing, we try to put about 40 to 50 follicular units in a square centimeter. Instrumentations is pretty simple. We can just use some basic surgical instruments, a forceps. We need good magnification. And of course, you can use video microscope. We use stereo microscope for dissection. And of course, tumescent technique. And let me see. This is a video which actually tells you how a strip is being cut. It's actually a parallel blade instrument. You can use free hand, you can use 2 free blades, or you can use a spacer. Here it's about 1.5 centimeters width of scalp is actually being removed. And this will be primarily closed. And this is how the strip is actually being harvested by distraction. And you can actually see the strip being dissected. The free margin is being cut, taking care not to destroy any hair follicle in the free border. And this is how the strip is removed. You can actually see the hair follicles, and what you're seeing is actually one edge of the strip. Now, this is actually slivered. You make them into, bits which are like SIM cards. It's just one hair follicle in thickness. And we have about 5 or 6 people who have been trained, and the job is to actually make them into very thin slivers. Each one is a SIM card thick, and then from that the hair is separated out. we need to follow certain angulations to see in what angulation the hair has to be inserted. This is the direction which we follow. There's something where the whirl is or the crown area, and then as it comes to the front, it follows a certain hairline. These are the routine typical instruments. There are blades available, but absolutely unnecessary. And then there are different methods. One is called a stick and place method. I'm going to show you a stick and place typically involves making a hole and inserting one hair into it. It's a very labor-intensive procedure. It takes anywhere between 3 and 7 hours of operating time. So usually I don't follow any dressings. Some antibiotics for about 5 days and steroids to reduce the swelling. We have a newer method now available which is called the FUE. This is FUT. FUE involves harvesting of hairs using a punch, which is about 0.8 millimeters. That means you actually project the path of the hair inside by visualizing it outside, and then we use the punch to actually go inside, and then you extract each hair. That's even more time consuming because each hair has to be removed, so it takes about 2 hours or so to extract about 1,000 follicles, and then they are to be inserted. The method of insertion is the same. This is FUE. What I use is the SAFE system. And I will show you, this is how the donor site would look like once the harvesting is done. Instead of a strip with a scar, this one, it will be holes which are about 0.8 mm. This is a combination of a strip and an FUE done. You can actually see the holes of the FUE made at the top of the scalp, and the lower one is actually the strip graft. The advantage of the FUE or the extraction system is that there is going to be no linear scar. So even if he has a very close shave or the hair is cut very short, the scars will not be visible. Whereas with the linear cut, you need to keep at least a centimeter of hair to cover it. Or any time the person has a head shave, the scar will be visible. The FUE takes longer, and it's got a longer learning curve. I'm going to show you some pictures of before and after. I think they're all self-explanatory. The line which has been marked is the projected hairline, and the hairline has been recreated, and you can see pictures. The hair usually falls off in about 3 weeks' time, and it takes about 4 months to start growing. So it's not an instant growth. It's just like a baby taking 9 months. This takes about 4 months to start. You need at least 1 year for you to get a good result. I mean, patient has to evaluate it at the end of 1 year, and maybe a second sitting might be necessary. And you can see these are surgeries which produce a tremendous impact on the individual. I don't think it's possible for me to explain. Some of the pictures might even have a smile on the individual, which actually illustrates to what extent it can change the body image. Majority of the patients are unmarried. They have a real problem because despite being well educated and placed very well, this forms a major issue in terms of their being in the marriage market. You can see all the patients. Some of them are older group, but majority of them are youngsters between 25 and 30 years. You can see the quality of result. If the hair is thick and coarse, you can get very dense result. This patient is specifically important because he's actually what we call a grade 7. You can see the front view, and I'll show you the top view. You can see he was totally bald, and I will show you a view of the crown. This part, you can see we have actually created the whirl for him. This took about 3 sittings, but you can see the amount of change that we can actually generate from the top view, and also you can see the front. So these are just illustrative examples of patients who have undergone procedures, and makes an impact on all the patients if selected properly. You can see the quality of the hair at the top, even when combed. And the important thing is, unlike the earlier techniques where not that the hair was not growing, but it was actually apparent that a surgery has been done, the current surgeries don't leave much of a telltale signs. Sometimes in women, we do the same procedure. You can have some complications like donor scar, which is wide. Sometimes you can get cysts. Sometimes you can get small pits, but majority of the times you can get good results. This is just to show you if it's placed very far apart, then it looks very artificial, and sometimes you can get small indentations. It needs a good team, and it needs a lot of patience to do this surgery. Thank you.